Good morning, everyone. Thank you for joining this session. Today we are part of the collective that has been joining the global public health during this week, where we are discussing community-led health promotion. Can you kindly mute yourself, those who are admitted? My apologies, just trying to see if there's someone who's not muted and there's sounds coming in. Thank you. I was saying that in this week, we are talking about issues of mental health, and since the 8th of April, there have been sessions where people have been in a dialogue discussing about matters in relation to mental health. And today our focus will be on the mental well-being, putting mental wellness on the agenda. And we are going to have a keynote address, and then we will also be having the panel discussions, and participants will be also allowed to have questions and answers in the session. So we are going to commence the session by having Dr. Saiendrah Moodley, who is the current president of the College of Public Health Medicine since October 2020 to date, and it's also a member of the council since October 2017 to date. And Dr. Moodley serves as the Senate of the College of Medicine of South Africa and its Examination and Credential Committee. He has served as a governor, moderator, and examiner for the FCPHM examination. Dr. Moodley is a public health medicine specialist and a senior lecturer in the Division of Behavior and Health Management Services, in the social schools, systems and public health at the University of Pretoria. He has a broad range of health system experience, having worked at the Office of Health Standards Compliance in the Department of Public Health Medicine as the Biko Academic Hospital / part of University of Pretoria. And he also worked in the Department of Health in the Western Cape. He has been a governor of the Public Health Medicine Registrar training program at the University of Pretoria since October 2010 to January 2013, and also came back in June 2019 to December 2022. Dr. Moodley, ladies and gentlemen, has previously served as a member of the Executive Board of Directors of the Public Health Association of South Africa and its Vice President and President. In addition to his medical degree and specialist qualification, Dr. Moodley holds a postgraduate diplomas in mental health, tropical medicine and health system management, and his research focus areas are public mental health and human resources for health. And his focus for the PhD was on mental health task sharing involving clinical associates. Welcome Dr. Saiendrah Moodley as our keynote address for today. Let us welcome with the emojis clapping for him. Over to you, Dr. Moodley.
Hi, good morning, everybody. I'm just trying to locate my slides. Can you just confirm if you can see it?
Yes,
we can.
if you can just put it on the slide mode.
Okay, yes. Is that fine?
Yes,
Yes,
it is.
Dr. Moodley.
Okay, great. Thanks, everybody. And thanks for that very long introduction. I'm sure I sent a shorter version to PHASA. So I think in terms of the overall theme for today, which is putting mental health on the agenda, obviously one of the major issues revolve around human resources for mental health. So what I'm going to do is kind of look at some of the work that I did for my PhD in terms of task sharing in mental health service provision.
No, thank you. I'm interested.
Particularly focused on clinical associates. So just to give you a bit of background, the PhD consisted of 3 phases. In phase 1, we reviewed the clinical associate curriculum. And for those of you that are not familiar with clinical associates, they are mid-level medical workers in South Africa. They do a 3-year degree, and they then meant to work under the supervision of medical officers, primarily at a district hospital level. So the phase 1 was looking at their curriculum. Phase 2 was assessing the readiness for clinical associate task sharing in mental health. And phase 3 was around identifying the key elements of a task sharing model. But just in terms of a background, I think we're all aware that there's a global shortage of human resources to deliver mental health services. And we can talk about psychiatrists, psychologists, psychiatric nurses, etc. And with the COVID-19 pandemic, that's increased the burden of disease due to mental health, which means we need more resources. And there are substantial disparities between countries. Just looking at the median number of psychiatrists per 100,000 population, you can see the vast differences between the
Dr. Moodley, we can't hear you.
You are muted, Dr. Moodley.
Yes, sorry. I think it was somebody that muted me on the other side. But I hope you can hear me now.
Yes, we can.
Yes, thank you. So in terms of the disparities between countries, that's quite obvious, but also within countries, there are disparities. And we're looking at South Africa specifically, the number of psychiatrists per 100,000 population in the public versus private sector, 0.38 compared to 4.98 per 100,000 population. And then if we're looking at rural health facilities, I think this was one study that looked at 160 rural PHC facilities, which found that 17 million people were being served by only 116 mental health nurses. In terms of national data with respect to prevalence and burden of disease, there's very little that's quite recent. People often go back to the South African stress and health study that was done in the early 2000s. But more recently, we have data from the National Income Dynamics Survey, which found that 29% of respondents nationally screened positive for depression, which are huge numbers. So we need increasing numbers of non-specialists to provide mental health services. There have been task sharing approaches used globally that have involved general practitioners and medical officers, nurses, and also lay workers such as community health workers. A number of countries have these mid-level medical worker programs. There's physician assistants in the US, for example, physician associates in the UK, and throughout Africa, they're called various things such as clinical officers, medical assistants, etc. We call them clinical associates in South Africa. They obviously receive some training in mental health in their undergrad degree, but we weren't sure how much this was and to what extent they're actually working in mental health services. So this was kind of a part of the reason for doing this PhD. And these were the objectives of the study. To look at the mental health content of the clinical associate programs, their knowledge, attitudes, and practices, to describe the attitudes of health managers, medical doctors, and nurses towards mental health task sharing, and to identify key elements of a mental health task sharing model. I've highlighted the third objective in red because that's what I'm going to focus on, because I think we got some useful information there beyond just issues related to clinical associates, but mental health systems issues in general. Just briefly on some of the other work that predated that. So in terms of the undergraduate clinical associate training program, we found that they do cover mental health, usually between, well, it's 2 to 4 weeks in the program, depending on which of the universities we're talking about. And the program is offered by UP, Wits, and Walter Sisulu University. In terms of their facility-based mental health training, and we haven't named the universities here, but at one of the universities, it's 2 weeks. At another, it's 3 to 4 weeks. And at the third, it's 4 weeks. In one hospital, in one university, they rotate specifically to a mental health unit. In the other two, they generally do their rotation at the district or regional hospital where they're based for the year. There's quite a bit of variation in terms of what is covered and how it's covered. One university uses a very practical approach, with them obviously seeing patients and clocking patients. Another is quite theoretical with limited practical exposure. And in the third university, depending on which hospital they are based, there's considerable variation in terms of exposure. So in terms of this component of the study, obviously we found that there were gaps in each of the programs, and we made recommendations in terms of how mental health training could be strengthened at undergraduate level. The second paper, we asked the academics as well as the clinicians involved in training clinical associates, whether they felt that it was a role for them in mental health. And overwhelmingly, the feeling was, yes, they should be playing a role in mental health. The appropriate settings were identified, and the feeling was that it should be at primary care and district level, and a number of tasks were identified in which they could be involved in terms of mental health. The view was expressed that they actually need additional training, and that could take the form of short courses and potentially advanced training in mental health. We've called it a specialization, but essentially we're talking about either a postgraduate diploma or an honors degree in mental health for clinical associates. And this was one of the quotes from one of the participants. They're very relatable to the majority of people that are struggling with mental health issues, and putting clinical associates at the front of these conversations and seeing these patients is definitely a good thing. So yeah, very positive. But remember, we were speaking to people involved in their training who obviously might have been slightly biased in terms of their views. Then we did a survey of clinical associates themselves, and working throughout the country. We obtained databases from 2 of the universities, their alumni databases, and we tried to locate clinical associates to participate through social media. So this was just an initial part of that, which was trying to develop a questionnaire that we were going to use in the study. But in the actual survey, we looked at their knowledge, confidence, and practices. And we found that their self-reported knowledge differed based on condition. 70% rated their knowledge of substance use disorders as very good, much lower when you looked at something like ADHD, attention deficit hyperactivity disorder. There were deficits with respect to their confidence in taking a mental health history, with only 50% feeling quite or very confident, 43% feeling quite or very confident to carry out a mental health examination. Interestingly enough, though clinical associates weren't specifically working in mental health, their current work, whether they were based at district hospitals, at GP practices, or at PHCs, I think up to 2/3 of them were already doing some mental health work in terms of taking a mental health history and mental health examination. So we found that they're already involved, but there were these deficits in terms of history taking and examination. We also explored their attitudes and interest in terms of mental illness. And we used something called the Mental Illness Clinician Attitudes instrument, which is a validated tool. And the mean score there was 37.55. I think that would be meaningless to most people, but it's actually at the lower end of the range, which is a good thing. It indicates less stigmatizing attitudes towards mental illness. In fact, it's one of the lowest MICA scores obtained globally. Which I think is very positive. And there was quite a bit of interest in working in mental health. Majority of them showed interest in working at a primary healthcare facility, even at 72-hour observation units and at specialized level, and significant interest in additional mental health training in terms of both short courses and in terms of a potential specialization in mental health. Okay, so getting to, I think, the part of the study that I wanted to focus on, which were the focus groups, which were phase 2B. And here we looked at the views of health managers and clinicians on the scale of mental health illness in their health services, the human resources challenges they were facing, and their attitudes towards the utilization of clinical associates in the mental health services. This was an explorative qualitative study using focus groups. We chose 4 districts in the country, and these were districts that we knew already employed clinical associates. So that was Sarah Bartman in the Eastern Cape, which is around the Grahamstown area, eThekwini in KZN, Katsabande district in Mpumalanga, and Dr. Kenneth Kahunda district in the Northwest Province. The participants were doctors and registered nurses involved in mental health services. This was either at hospital level or at PHC level, as well as health managers. So health managers from the health facilities, as well as health managers from the district office that were responsible for mental health. In terms of sampling, we used purposive sampling to ensure that all of the focus groups combine a mixture of people working at hospital and at clinic level, as well as a mix of managers and nurses and doctors. So the number of participants in each focus group ranged from 6 to 8, with across the 4 focus groups that added up to 29 participants. We conducted 3 of the focus groups in the boardrooms of the hospitals that were selected. So kind of the main hospital in that sub-district. I think one of the focus groups, the one in eThekwini, we actually held at a private conference venue because we couldn't find a location, public sector location that suited everyone. I facilitated the focus groups, and there was an observer present at each. These were audio recorded, then professionally transcribed. We send the transcripts back to the focus group participants for member checking. We did the analysis in Atlas TI with thematic analysis and developed themes and sub-themes. Just giving you an idea of who participated, in terms of age, almost half of them were in the 40 to 49-year group, roughly 50-50 in terms of male and female. The majority of participants were nurses. We had 9 medical officers and 3 medical specialists. 16 of them were doing purely clinical work, 9 had a purely management role, and 4 had a mixed clinical and management role. And as I said, we had participants from CSCs and clinics, from the district hospital office, as well as from hospital level. So these were the themes that emerged from the interviews, the focus group interviews. Number 1, mental illness is not going away. The health system cannot cope with, the health system cannot cope with mental illness. Clinical associates could be part of the remedy. And, you know, there was a feeling that it would be useful to have the specialized clinical associates in mental health. Looking at each theme, mental illness is not going away. So the participants spoke of high rates of mental illness, which are increasing, and they felt that they were actually really only managing the tip of the iceberg. There was a surge, or they were seeing a surge of substance-related presentations, and that was throughout in all 4 districts. Other disorders and presentations were quite common as well, such as depression and anxiety. Interestingly, and this also emerged in all 4 of the focus groups, that the patients they were seeing were getting much younger, and they related that also to the fact that it was you know, these dual presentations involving substance use as well. High rates of relapse and readmissions. So there was this concept of the revolving door, where people are discharged with no services available in the community. And I think this is probably something the panel will pick up on as well. You know, no rehab, no outreach. Patients then just relapse and have to be readmitted. And there was also the view that social determinants were largely underlying the high rates of mental illness. And the one that emerged quite strongly was this issue of unemployment and mental illness. The health system cannot cope with mental illness. That was the second theme. And this was put down to the fact there was a lack of prioritization of mental health and mental illness, both in terms of the budget allocated as well as the fact that there wasn't this political will to implement policy. So participants spoke about the National Strategic Plan and policy framework that looked good on paper but was never implemented, and the neglect that they were seeing both at national level as well as in provinces. Shortage of mental health units and beds, that was something that colleagues mentioned, participants mentioned, where often patients had to be waiting in emergency units of district hospitals for extended periods of time because there were no beds available for mental health. Deficiencies at primary healthcare level, and that was both in terms of just the lack of capacity to do anything in terms of screening and management. Where there was capacity, there was a lack of appropriate capacity in terms of numbers. There was a lack of appropriately trained staff. I think the comment was around the fact that the approach is still very much hospice-centric, sorry, not hospice-centric, hospice-centric, in that, one waits for patients to deteriorate, and then only do they get access to kind of services with, very little happening at primary care level. Obviously, there are human resources for mental health constraints, with the lack of specialist staff, but also the generalist staff not having appropriate training in mental health. So the view was that clinical associates could be part of the remedy. Currently, their roles consist of very little mental health, but their performance in other disciplines is promising for their utilization in mental health. And people felt that, just extrapolating from how they've worked in other disciplines with the appropriate training, they could be utilized. There were obviously constraints and barriers to a role in mental health, such as their scope of practice, the fact that they need to have medical practitioners countersign prescriptions was a limiting factor. The Mental Health Act, which obviously predates the emergence of the SCADA, it doesn't mention clinical associates as a mental health practitioner. So that's another issue that needed to also be addressed in terms of potential barriers. But as with the initial part of our study, when we interviewed those involved in the training, they also, in this group of participants, they also identified potential roles, such as working at a PHC level in terms of doing some of the initial management, screening in emergency departments, doing the initial assessment when people come into district hospitals, etc. So there were potential roles for them, but there was a feeling that actually having this advanced training could actually be more beneficial in terms of mending the health system, because they would potentially add more value. And the suggestion was an additional year that they would do in psychiatry. Obviously, these are people that were interested and wanted to further their training in mental health. Barriers in terms of employing the specialized clinical associates would have to be addressed, such as creation of posts and looking at salaries, etc. And there needed to be a differentiation between the roles of somebody that's had this advanced training versus those that just had the undergrad training. But also from the clinical associates perspective, the specialization might also help them with having more opportunities as well as creating a career path. So I haven't provided any data here from phase 3 of the research, which was a Delphi panel involving psychiatrists and family physicians, where we looked at in more detail as to what needed to be covered in undergrad training as well as in a advanced qualification, and what specific tasks they should carry out based on that training. I will shortly be publishing on that, so that will be in the public domain as well. But I think there were interesting results there. But in terms of what I presented today, I think we can agree that there are significant challenges in providing mental health services in the public sector, with a substantial issue being the fact that we lack sufficient human resources, and particularly specialized mental health personnel. But we also have non-specialists who are inadequately prepared to deliver mental health services. Clinical associates could play a role if their undergraduate training is strengthened. There's a postgraduate offering for them, and if we address structural barriers. So I think that's where I end. Those are my references, and particularly for the focus groups, I need to acknowledge the observers as well as the person that did the transcription and the funding from the University of Pretoria. So I can hand back to Constance.
Thank you so much, Dr. Moodley, for the presentation, highlighting the outcomes of your research and also the challenges that have been faced by the public sector in ensuring that we offer mental health services that will benefit the communities. And it is clear that the outcome of the research shows those human resource challenges that are there. And it is very important for us to ensure that we have a resilient health system. And this research will basically assist even the government to ensure that we improve on services that are offered and ensuring that there is access to the community on mental health services. What is very interesting is that we're able to go to the district level where services are offered, and it was really informative and very useful. As they normally say, we need to use evidence-based to plan outcome-based outcomes to plan, and this research will definitely assist the government planning further to improve on provision of mental health services. Thank you so much. We really appreciate the presentation and the research that we have done. So we are going to move to the panel, but I'm going to request our panel to introduce themselves before we go to the panel discussion. And I will just request Prof. Robertson, if you can just introduce yourself.
Good morning. I'm Lesley Robertson. I'm a psychiatrist in the Sedibeng District Specialist Mental Health Team of Gauteng and at the University of the Witwatersrand. Thank you.
Thank you so much, Prof. And I'm going to request Prof. Ramneek also to introduce himself. Prof. Ramneek, you can unmute and introduce yourself. Okay. While Prof will be coming back to us, we'll ask Dr. Nyembezi to introduce himself as well.
Good morning, colleagues. I hope you can hear me.
Yes, we can.
Okay, thanks. I am Anam Nyembezi, and I work for the School of Public Health at the University of the Western Cape, and I'm also the chair of the Health Promotion Special Interest Groups. Thank you.
Thank you so much, Doctor. Dr. Nondumiso, you can introduce yourself.
Good morning, colleagues. I'm Dr. Nondumiso Tshuma. I'm with the Best Health Solutions. I'm a public health specialist. Thank you.
Thank you, colleagues. These are our panelists for this session, and we are going to have a discussion, and kindly jot down your questions that when they are done doing their brief presentation, then you will then engage with our panelists. And I'm just going to start with
just to allow that I am also in the meeting. My name is Professor Ahluwalia, just to inform everyone. Thank you.
Yes, Doctor, I was calling on you to introduce yourself. You're welcome.
Thank you, thank you, thank you, Chair.
Thank you. As I indicated, I'm going to request Prof. Robertson, just looking at what Dr. Moodley presented on the research that has been done. Why do, he has also given some rationale behind the importance of putting mental health on the health agenda. If you were to emphasize the importance of putting mental health on the health agenda, what are the issues that we need to look at as a country in ensuring that we really put mental health on the agenda and ensure that our communities do have access to mental health services? Dr. Robertson?
Thank you. Thanks, Constance, and thank you, Dr. Moodley. Saiendrah, that was very interesting research and really timely and much needed. So why should we put mental health on our health agenda, or our public health agenda? I think to start with, we're spending a huge amount on mental illness. We're spending it in our health system and our correctional services, our unemployment, our insurance policies. There's family, removal of children from care, social issues. So we're really spending an enormous amount of time and energy and money, and we have absolutely no idea what we're getting for our money. So just to go back to the Mental Health Care Act, this was promulgated in 2004, and it dramatically changed the setting, the treatment setting for mental illness and the range of mental health that we should be managing. So it changed it from a specialist standalone hospital to care in a general health setting. And Regulation 2 of the Act requires that patients are discharged from tertiary units back to PHC, or community services. And it's not been on the agenda. So for 20 years, we've been implementing this act with no program guideline, nothing to educate and train our non-specialists or people in community settings as to what they need to know. And I think this use of clinical associates in particular, it would be really fantastic in this regard. In keeping with this, we've had a continued disproportionate resourcing by government of standalone specialist hospitals. So patients are discharged to where there's no resources and no training. Furthermore, we've got no outcome measures, no meaningful health indicators. I think they have now introduced suicide attempts, and we obviously measure suicide rates, which get sent to the WHO. The other indicators are simply to try and gauge something about disease burden or care burden and are very unreliable. Then lastly, I feel it should be a public health agenda item because it requires primary, secondary, and tertiary care approaches across all disciplines, not just psychiatrists or psychologists or occupational therapists, but it really needs a person-centered or patient-orientated outcome measure and outcome-focused attitude to developing the services. Thank you.
Thank you so much, Dr. Robertson. And I agree with you that if we have clear guidelines on program implementation for mental health in the public sector, we will be in a position to improve on service provision and also having those clinical associates to assist at that level. It will be critical. You mentioned a very critical issue about issues of not having meaningful indicators. Yes, we do have the Act, we have other documents, but the implementation became a challenge. And I think we need to be intentional in terms of implementation of mental health services. We as in the public health sector, we have to be vocal about it, if we were to call it activists in a way, to ensure that we elevate our voices in ensuring that mental health issues are taken care of and all professionals and clinicians are part of it in a multi-sectoral way, so that everyone is involved, including the communities, and we hear their voices as well to ensure that no one is left behind. And thank you so much, Dr. Robinson, for your take on this. Moving to Dr. Nyembezi, I just want to know, based on what Dr. Robertson has shared and Dr. Moodley, which strategies should we really implement at community level to promote mental health in general before illnesses occur? Looking at what Dr. Moodley spoke about young people being the most affected. What are those strategies that you think will really assist us in improving the implementation of mental health services at community level? Over to you.
Thank you very much, Constance. And again, congratulations to Dr. Moodley for giving us an insightful presentation, and congratulations on your research. As you were presenting, I immediately, when you were presenting and talking about the age of the people that are presenting themselves with mental health issues, I thought about that we have over about 3 million of not in education, not in employment, or not in training adolescents or population in South Africa. So that kind of like gave me like an understanding maybe of saying maybe that could be one of the reasons why we have these numbers in terms of people that are developing mental health issues. And I think one of the strategies that we can use is to think about education and awareness. I think in this group, we need to make sure that in the communities, we organize information sessions, health information, to provide education into the community, so that they can know about the mental health, the common mental health disorders, and the importance of seeking help. So I think that could also be important to think about collaborating with other professionals or even other people that are providing services. As I was thinking also is that you mentioned that there is a human resource constraints. So I was thinking about that in South Africa, we know that the number of traditional and faith healers, they far surpass the number of mental health practitioners. And I was thinking that in rural areas, I mean, in South Africa, we know that we have rural provinces and districts. And so I was thinking that we can leverage on that and include them and collaborate with them in terms of having these sessions where we provide information to the communities, and even be part of the screening, the counseling, you know, and in terms of when we facilitate those such, so that at least we can be able to know and impact knowledge to people and to know about these issues. And also, I was thinking that this can also be done in terms of like, if these wellness, mental wellnesses, they can be integrated into the community events. We can use opportunities, for instance, during the grant payments, during the imbizos, you know, and community events, and have opportunities where we offer information about mental health, self-care practices, stress management, and the likes. So we can have events where we organize fun and engage activities so that we promote relaxation and the likes, things that promote wellness and well-being. And then issues of coping strategies and resilience, also we can also think about those issues. And I was thinking about the young population, that since majority of them are also in school, so we can also think about workshops and training sessions where we can have some coping strategies, building resilience, you know, techniques that are used to develop anti-bullying approaches, because it cut across from lower schooling, lower grades, all the way to the universities or universities. So we can have curriculums that are developed for scholars or for this young population in terms of giving them some information about coping skills, about also health promoting environments that they can. So those were my insights when it comes to your presentation. But I think the colleagues that are in the panel and in the sessions will add more. Thank you.
Thank you so much, Dr. Anam, for your take on this matter. And just to request also Prof. Ramneek, as you cover the, you can also cover this question to say, add on the strategies that you think could be considered, looking at the challenges that young people are facing. And also just to say that in terms of the National Strategic Plan for HIV, TB, and STI 2023-2028, mental health services was elevated and prioritized to be included in this plan. And what do you think should be prioritized? And looking also on those strategies that are targeting young people and children? What do you think should be really prioritized to ensure that there is access of services at community level? Also looking at the outcome of Dr. Moodley's research. Over to Prof.
Thank you, Chair. Chair, if Ms. Isa can mute herself or himself, sorry, Chair. There's a lot of background noise, Chair, with your permission. Thank you, Chair. Yeah, thank you, Chair. Chair, greetings to everyone, and fantastic presentation and research by Professor Moodley, and to my speakers before that, quite insightful, and congratulations to you, Chair, for organizing, and to PHASA. Chair, there's a lot of, as everybody said, mental health is a kind of a sitting time bomb, which, if not tackled, has a huge bearing on our country's economy and in total every sphere of this. And Chair, I'm going to speak about some of the interventions that are already taking place and have shown great results and can be scaled up, which are coming out from some of the national strategic plans, the white papers, the NDP 2030, and things that we have now inserted mental health at a very strategic level, as not only as a nation, but from a global perspective, considering its bearing on our country, on a global economy in general, and on human resource or workforce, and in practical reality called skills building systems. So, Chair, say higher education, where all our universities are there, our TVET colleges are there, community colleges are there. This is where the next generation of workforce is coming. Miners, electricians, plumbers, doctors, engineers, every workforce predominantly is coming. And then there is a schooling system where there are children coming out from grade 12 onwards, from matric. Some do enter into education, some do not enter into further education and go into workspaces. So right from primary education, secondary education to tertiary education. Now, as a government, as systems, what we are thinking now is, with the data that suggests that 50% of symptoms of mental health starts coming before the age of 15, and 75% of total cases, symptoms do start coming at the age of 24 or earlier. Considering that picking mental health at early stages becomes a predominant reason of what systems and structures needs to be put in place if we have to curtail mental health, which means we do not want to leave mental health to a level, as Professor Lesley or Professor Moodley spoke about in detail, that it comes to a huge economic burden to our country. Productivity falls down, a human becomes a patient of mental health, and then the whole cost towards repairing or working, which sometimes are irreparable to a level that it goes to an extent towards. So I think early stages of interventions and early picking of mental health, early resilience building in mental health will go a long way. And I'm talking about investment into prevention. And that's what I'm going to give you a model, what we are doing. What we have prioritized is that every student in the post-school system, whether you are from grade 9 onwards, which is after NQF level 1, which is right up to basic literacy level, we have now built a skills program on mental health, which is accredited through QCTO, which is a quality council with SAQA at NQF level 5. So anybody NQF 1 can join, but exit out of NQF 5. We have not only tackling mental health, but mental health remains a very important and the biggest module in the soft skills qualification, which every young person has to learn and understand, but in a very basic literacy level built. But on the other side, it's other modules which intersects with mental health is gender-based violence and gender equality, gender diversity, the whole gender transformative education, the civic education, drugs, alcohol addiction, abuse, climate change, comprehensive sexuality education, and many more other challenges that remain in South Africa. And that has come out as a kind of as a new thinking towards early intervention thinking. So education starts playing a role. And from there, we have started something called early risk assessments on young people, specifically the ones who are consent age, can start doing their risk assessments while they're being educated as part of some of the assignments of this qualification. And the aim is, can we pick young people at early stages, and can they come out to ask and fight the stigma towards seeking help? And that is the stage where the situation of the Professor Moodley's presentation of associates, nurses, and stages of psychologists, psychiatrists, the whole mental health system then starts coming into reality for what we are trying to address, and at what stages do we need to intervene at quick stages at lower levels versus referrals to the higher level. And a pathway needs to be built from prevention at early stages of education right up till a stage where intervention needs to be brought into place. In higher education, we have done a three-way treatment program. So every case who is now, so we have got now in last 2 years, 68,000 linkages to mental health. And that's a very high number of burden that as post-school education out of a population of 2.2 million people, we have started seeing these cases coming out. And we have increased this number drastically from a very few small number that we used to see, because we knew the epidemic remains high, but it was so hidden that people were not coming out. There was no systems towards informing, picking up, fighting stigma, and bringing them to care. But then to handle 68,000 is another big challenge. And we are doing it in forms of peer counselings. We are working towards group counseling mechanisms at very early stage interventions, towards CBTs and therapies that goes towards counselors and psychologists levels, and then a deep referral to psychiatrists when needed. But we're seeing early picking does take lesser interventions towards late picking, where the disease eventually has evolved. And I'm not talking about mental health diseases in totality. Of course, schizophrenia at early stages needs the same kind of intervention, but whereas an early line of depression or an early sign of anxiety takes a different note towards an extent of depression or extent of the damage on mental health challenges go into deeper. So what we are building now is community interventions at far more early stage, while fighting stigma, which is very critical, building more education, building mental health in the form of a skill, towards also where the private sector is investing money with us, because the private companies want these soft skills for their own productivity at early stages with institutions of learning or education systems. We have put now mental health as kind of mandatory. Now we're working very closely with UNESCO to work with DBE for all teachers training, in order for us to ensure that the teachers who are building systems in schooling system understands the early signs of mental health and how to address to a young learner who is in the same class and be supported at early stages. So for us, the whole focus of our planning is early picking, early intervention, early mental health resilience, early skills building, in order to reduce cost eventually for our mental health. And that's where the new strategy goes towards in our thinking. The NSP is a great start to us. It's taken us 14 years of continuous engagement to this new plan that now puts mental health right as a KPA, as a key performance deliverable for a national strategic plan as big as for 8.1 million South Africans that are living with HIV in South Africa. And that's one big element that we had to come to the realization that we can't fight HIV without not handling the mental health challenge, which actually affects our prognosis on the HIV in a deeper way. But on the other side, we kind of working now with the Human Resource Skills Development Council chaired by our Deputy President, which is, and SAMAC is one area with the NSP sits on HIV under Deputy President, but then there's a Human Resource Development Council that also sits under the presidency where the whole next generation of workforce is working, where mental health becomes a critical enabler. We're now putting the similar emphasis under white papers in different government entities like the basic education, the higher education. So mental health needs to resonate out of from a national strategy into departmental strategies, investments into these strategies, and then going layer by layer in putting infrastructure around it. So no one must only be, mental health cannot be sitting just in a mental health unit. That's the last area. Mental health must be starting into from the schooling system infrastructure, higher education schooling infrastructure, and then only the referral pathway go towards cases of non-management or difficult management into the linkages into the tertiary system. So Constance, that's where the strategy is on how we're dealing with communities, how we're using schools and education system as the first stance towards it. Thanks to the government that we also now working with NEET on this matter, which is people not in education and not in employment, to be part of this skills development program, and where mental health remains a critical enabler. So I think we tackling mental health from a very strong educational perspective, right into a qualification, into credit-bearing courses, kind of building mandatory systems in the system for young people to know about and understand, and to build a resilient society in our system. So for me, cost effectiveness starts from prevention, and investment needs to be put into prevention at a very early stages. Thank you.
Thank you so much for highlighting the importance of early identification and intervention of mental health conditions, and also touching on the importance of skills development, where you also emphasize the importance of peer counseling and peer group counseling. And I think this will also address the challenges that Dr. Nyembezi indicated, the challenge of bullying, which is not only in schools, but it's also in the workplaces, and also translating into gender-based violence in the homes and so on. And it is clear that there is work being done in the communities, and there is work being done by the government and various institutions to ensure that we address mental health conditions. And yes, we are intervening, but it's not yet enough. We need to escalate this to ensure that everyone in the community do understand the importance of mental health. And I'm going to move to Dr. Tshuma just to say, why is it so important for us looking at the research done by Dr. Moodley, where he indicated that when you look at mental illnesses not going away, he mentioned that mental illnesses are in an increase, and there is this issue of substance-related presentations coming in. And to me would be, how do we educate the communities, especially young people, to understand the importance of their own mental health throughout their life journey? As Dr. Nyembezi, as well as Prof. Ramneek, they mentioned that yes, we do have young people who are not in training or in employment, and we need to ensure that we reach out to them and they do understand the importance of mental health. What do you think we need to do to educate our communities around this? Over to you, and just reflecting also on the research done by Dr. Moodley.
Okay. No, thanks a lot. Thanks a lot for the opportunity, and thanks a lot for convening this particular session. I must say that there is a lot to pick from my previous colleagues, and I'm going to reiterate the same sentiments that my colleagues have highlighted, Professor Moodley, Professor Ramneek, and Dr. Nyembezi, particularly in the space of early interventions. The need of making sure that the issue of mental health gets to be attended to as a major priority, and gets to be attended to as early as is possible. And I must pick on one of the aspects that says that for us to effectively educate the community, particularly young people, on the importance of their own mental health throughout the journey, it is essential to adopt a much more comprehensive approach that integrates principles of both mental health promotion and also reframes the public health programs, where we integrate mental health into existing programs and existing funding. I must also acknowledge the fact that there is a lot of great work that has been done by institutions like Higher Health, particularly in the space of the development of risk assessment tools, those that are targeted at students. I think Prof. Ramneek actually spoke a bit around that particular part, but there is a need for us to adopt and adapt and potentially scale up the approach that is presently being used by Higher Health of undertaking those risk assessment tools and potentially looking at it at a much more broader scale, looking at community-based organizations or civil society organizations that could roll out similar tools, of course, through Higher Health doing the capacity building of the broader community and the broader institutions out there. I believe that through those kinds of approaches and adapting and adjusting it to youth in the community, to teenagers in the communities, we are likely to come up with much more targeted interventions so that young people would be in charge or in control of their own mental health. But over and above that, I think there is an aspect to do with engaging community members and young people in particular. This could look at making use of participatory action research initiatives or human-centered design approaches that go into the community and understand exactly what are some of these drivers and what are some of the potential solutions, but from the perspective of the youth themselves. There is an aspect to do with us engaging with the youth or the youth engaging with the youth at a grassroots level, whereby we begin to gather information on how best to document and disseminate and tailor messaging on mental health, particularly amongst the youth. And this could be done even through youth-led institutions or youth-focused institutions like Higher Health. And this would allow us to gather information in terms of what works, what doesn't work, what are the most ideal strategies through which we can disseminate mental health messaging, not only targeted to the youth, but also targeted at institutions that are providing services that are targeted at the youth. Because you would find that there is a lot of space or that could potentially be occupied by the healthcare workers, by civil society organizations, by the youth themselves, particularly when it comes to harnessing the power of diverse educational platforms to reach out to these youth, particularly when we talk about the utilization of digital platforms, social media, the mobile apps, or online forums to disseminate mental health information and resources. And you would find that through risk assessment tool, through all the kinds of readily available messaging, we could tailor some of that particular messaging so as to reach out to these youth that are in the communities. And I strongly believe through getting youth to take a leading role, we are most likely to have interventions that are tailored and which would increase the understanding of mental health, not only amongst the youth, but also amongst the parents of those youths or the caregivers of or those that are institutions of higher learning. Thanks a lot.
Thank you so much for your input and your take on this matter. I facilitated this in this manner so that I give audience more time to ask questions to our keynote speaker based on the presentation that was done, and also on the areas that we have touched with our panelists, so that we start engaging with our panelists and also our keynote address speaker, Dr. Moodley. So I'm going to open this session now for questions from the audience, and I will really request those who will want to make comments or to ask questions to our panelists and our keynote address speaker, Dr. Moodley, to do so. I can see hands coming up, and I'm just going to use my participant list to call out those who have, and then we'll have various rounds in the session to ensure that we now have 4, and I'm going to give Dr. Francis the opportunity to give a comment, and then followed by Prof. Takalani and Lillian coming forth. I can't see the 4th one, but I'll see who that is. Over to you, Dr. Francis.
Thank you, Madam Facilitator. My name is I'm Professor Francis Yera from Walter Sisulu University. Thank you so much, Prof. Moodley, and congratulations for the work that you have done and for enlightening us on the whole work that you are doing. And especially congratulations for considering on the clinical associates to be on this work in terms of the mental health. I just wanted to comment that in some other countries, actually the clinical associates are taken back to school after working for 2 years in the clinical discipline. Then they're taken back to the university where they specialize specifically in psychiatry and mental health. So after finishing those 2 years, they become actually much more disciplined in terms of psychiatry. That means they are now given the mandate of prescribing to the psychiatric patients or to the psychiatric wards, and also to the mental health patients that are within them. There are also other disciplines which people are sent, these clinical associates, like in anesthesiology, obstetrics and gynecology, and also in the discipline of surgery and internal medicine. Once they've finished these 2 years in the universities, they're called assistant medical officers. That means they're already allowed by the professional body to become people who can prescribe and take care of these patients. So I think with this audience that we are having, it's just a suggestion that probably we can also take this or go and benchmark this in these countries so that we can utilize effectively our clinical associates instead of now seeking a counter-signature once they have seen the patients. Thank you. Thank you, and
so
over.
much. Thank you so much, Dr. Francis. I'm going to give to Prof. Takalani. Your hand was up.
Thank you so much, Connie, for this opportunity. I am Takalani Tshitangano from the University of Venda, Department of Public Health, Faculty of Health Sciences. I really am grateful for our keynote speaker and our panelists for the insightful discussions you are bringing forth. In acknowledgement of the great work the Higher Health is doing around mental health, my question goes to all of you to say, what can we do to have mental well-being promotion skills in every individual's mindset, the way COVID-19 preventive measures were? You know, as we were going around during COVID-19, everyone would know that I'm not supposed to be next to someone else. Social distance. I'm supposed to wash my hands, you know, just like that. So I'm asking, because we see that mental health is like a time-ticking bomb globally, which might affect our economies. What can we do to have mental well-being promotion skills in every individual's mindset, the way COVID-19 prevention measures were? Thank you.
Thank you so much. I'm going to take this too, and because this the question from Prof. Takalani is going to all of them, I'm going to allow Dr. Moodley to come in and just respond to you know, that recommendation in terms of benchmarking on the use of clinical associates, and also on the question that has been made by Prof. Takalani, and then we'll move to other panelists to respond to the question from Prof. Takalani. Over to you, Doctor.
Thanks, Constance. So to respond to Francis, yeah, so I mean, I think we are aware that this additional period of training in some of the medical disciplines does take place in other countries in Africa post the initial undergraduate training for the clinical associates. So that's definitely something that I think for us specifically in terms of mental health that we are looking at and introducing in at least one of the universities this additional qualification in mental health. So currently, the only additional qualification that exists is in emergency medicine, which is offered at Wits University. So we will benchmark against some of the other countries in terms of what's covered in their programs before we put that together. As I said, in the third phase of my research, which was the Delphi panel, we actually did look at you know, what should be included in a postgraduate curriculum, both in terms of the disorders that need to be covered and the kind of skills that clinical associates would need in order to be effective in mental health task sharing. So definitely issues that we are considering. I think in terms of the second question raised by Dr. Takalani, yeah, I mean, I think that's a difficult one. Obviously, we need to strengthen advocacy with regards to some of these mental health issues. I think part of the problem is that you know, a kind of lack of awareness on just how widespread the problem is in terms of burden of disease. And, you know, you're looking at sort of 1 in 3 people having a mental disorder at some point in their life. So I think we just need to get that information out there, improve awareness. But also I think we need to address issues around stigma. I'm surprised that I haven't heard the word stigma come up yet in our conversation, but in lots of the other work that we've been doing here at UP around mental health, I think one of the major issues in terms of accessing services is this whole issue around stigma and how people with mental illness would be perceived. So, for example, even when these services are available in employee wellness programs, people do not want to access it because they're afraid of the stigma that would be attached to them in the workplace. And I'm sure the similar issues apply at higher education institutions and so on. So I think, yeah, I definitely think we need to look at that issue. But I think part of it is for organizations like PHASA and the special interest group within PHASA to kind of take up some of these issues and get attention on it through social media, doing media statements, interviews, etc. Thanks, Constance. Back to you.
Thank you so much for your take on this and the responses. And Prof. Robertson, your take?
Thank you very much. So I'm going to talk mostly about getting the well-being promotion skills and everybody's mindset similar to COVID-19. And if I may, could I also answer one of the questions on the chat about PHC indicators, or should we wait till later?
No, you can also take that one.
Okay.
Yes.
So I think from getting the well-being promotion skills into mindset, for me, the biggest challenge is how do we simplify the messages to reach everybody? I think Prof. Ahluwalia's talk on what they're doing is tremendous, and it would be very useful to have their skills training that they're giving in shared, or at least what can be in the public domain shared. But to get into COVID-19, it's you have, I mean, to get it in the same way that you have messages about an infectious disease prevention, you really want to simplify things into, say, 5 steps. And this is perhaps not so easy. We tend to complicate mental health conditions. We've got this huge range of conditions, from normal human conditions through to psychosis and severe neurodevelopmental disorders and severe neurocognitive disorders. To my mind, we should have 5 steps, and I'm thinking off the top of my head, something like to have developed self-awareness, even 2 steps, develop kindness, tolerance of people who are different, gentleness, justice in our society, awareness of people's disabilities. This is what's lacking, so that we reduce stigma by increasing sensitivity and kindness for those who are either going through something difficult or who have a different makeup to the rest of us, neurodevelopmentally a different makeup, autistic spectrum, psychotic disorders. We've seen in our media huge mockery of people like Zandile Mafe, who went without treatment. His first episode, according to the media, was at the age of 15 of aggression. Never, ever recognized, never treated.
When am I going to Durban again? Which I think I will be soon.
My apology for that, Dr. Robert. Can you unmute yourself?
That's okay. But so that to me is the way to get well-being promotional skills. It's not just our own self-help and self-awareness, it's awareness of the other. And something that I was reading about in terms of public health ethics is a concept of relational autonomy. And I think that's summarized in Ubuntu philosophy. And I would like to see more of that in our awareness. To go to being more scientific, I think the indicators, and I really appreciate that question, because we go to our chief director in our district and they don't see why they need to, why do we need to be paid for what we do? Because there's no outcome measure. And the difficulty there in getting meaningful indicators, these indicators we have are not meaningful at all. And we know that because there's no analysis. There's nothing in the South African Health Review. There's nobody worries about the district health barometer. They have zero meaning for anyone in healthcare funding and management. The new one of suicide attempts is meaningful, and meaningful to accident and emergency units, to physicians and internal medicine, to ICUs, to surgeons, to everybody, because they're experiencing the burden of these. And we could work on a program then of how to reduce suicide attempts. Another one could be readmission rates. We've got a baseline data from the national costing study by Dukhi et al., which shows that 24% of admissions nationally are readmissioned within 3 months. I think some district hospitals are experiencing many more than 24%. And so these are two which could be used. Others are perhaps more about therapeutic outcomes. In our district, we do M&Ms, and we're looking at premature mortality where we know of it amongst our patients who access our mental health services. But these are more difficult to measure in our country where we don't have patient registries and linked registry data. Even if we just have the suicide attempts, the readmission rate, it would help us in our health system, but it would also mean that we've got to improve our collaborative care and with other sectors. We cannot reduce either suicide attempts or readmission rates without working collaboratively with education system, with correctional services, with SAPS. And other indicators should be in the other sectors: education system, dropout rates. Are we reducing our dropout rates? Who drops out? People with ADHD, kids with substance use disorders, those with emerging personality issues and problems, and occasionally somebody with bipolar disorder or psychotic disorders. So the dropout rates is a feasible indicator, and then to examine who's dropping out and what are we doing with them. And that again has to be collaborative across sectors. So those are my two answers. Thank you.
Thank you so much, Dr. Robinson. You know, when you came up with this indicator of dropout, to say what are the reasons behind the dropout, very, very interesting, especially in the education sector, because there may be really various factors that are influencing dropout. I'm going to give Dr. Nyembezi your take on Prof. Takalani's question.
Thank you. Well, I think I don't have much to add from what Prof has just made submissions on how we can go about dealing with the issue. I think for me, I think recently I read the Happiness Report 2024, and it definitely shows that low-income countries are rating very low in terms of their happiness and their life satisfaction. And these are some of the things that we really have to think about in terms of, as South Africans, how do we rate in terms of our happiness, and do we have to consider the social determinants of health in terms of how they contribute in terms of our livelihoods. And also one of the things that we can also think about in terms of the strategy that government is trying to put in place in the schools and the universities. I don't know whether in part of their curriculum there is something that is added, like the emotional intelligence of our young people, because that's one of aspects that we can also consider, in terms of how our young or adolescents and young people can be given skills in terms of improving their emotional intelligence when it comes to their approach in life. And also, I mean, I was quite disappointed with some of the observations when I was doing my research in the Eastern Cape among men that have been admitted into hospitals after some challenges with regards to traditional male circumcision. And we did a survey in terms of assessing their wellness and well-being in terms of anxiety, because so they experience trauma for them to be admitted after traditional circumcision. They've experienced trauma, they've experienced depression, they are anxious about how the community will welcome and stigmatize them and call them names. And we've seen some suicidal attempts in terms of the experiences of these young boys. But I was disappointed because the hospitals, I must admit that they don't have any tool, any instrument, any screening. So they just treat the boys and then they discharge them. As long their main responsibility, basically, it was just to deal with the issues that they're admitted for. But there was no any psychological evaluation. There is no referral system, and there is no social work. So in our tool, we did try and find ways of understanding from the healthcare professionals in terms of what can be done for the mental health of these young boys. And that's one of the things that we are trying to develop with those facilities. But it's just one aspect of community. So all I'm saying is that these are there are possibilities, and in terms of how we can use settings as one approach in terms of dealing with mental health issues, where we can already now have identified that schools as an opportunity where we can say, how do we deal with school goers, and including in higher education. But thank you very much.
Thank you so much for your input. And Prof. Ramneek, do you have any input to Prof. Takalani's question?
Prof, I'm so sorry. I had to change the device because there was a small internet problem in our premises. So I missed the question. I must be very honest, but I'm picking up from when I joined back. It was Professor Robertson saying a few things, and Dr. Adam. But can you just let me know what it is so that I can respond onto that?
Okay.
Sorry, Chair.
She was saying that how do we make sure that people in their minds, they think of mental health, they well informed, before we even have conditions that people are well informed about mental health.
Connie,
Thank you,
can I
She wants to come in.
ask it?
Okay. Okay.
Prof, thank you so much for coming back. My question was, what can we do to have mental well-being promotion skills in every individual's mindset, the way COVID-19 preventive measures were?
Prof, this is a fantastic question. And what we have done is we have looked at, so there were many problems that we were solving. the first problem we are solving is that a lot of workspace people came to us and say, soft skills needs to be put together. And if you look at the soft skills, what needs to be built when we are building hard skills in any system, one of the soft skills, we talk about empathy, talk about counselings, talk about mental health resilience. And there are, if you look at the 10 soft skills of the workplace that has been in the charter, predominantly more or less 70% of them speak to mental health, irrespective. Building a human which is more mentally sound, mentally well-being, in order to increase productivity in economic dividends. And I think if there was so much of a work towards human resource development from that angle, and then we already know we are sitting with a major epidemic like mental health, where WHO says 1 in 5. Some of our higher education studies are showing 1 in 4. These are 25%, 20% of the whole population network that's at risk to mental health. So we had to come up with innovative solution of building skills on mental health. And we took mental health from a skills perspective. And so every young person in South Africa should, in its curriculum, learn about mental health. And you're totally right, the previous speakers. It's not just mental health like the things like we know, the anxieties, the depression, the understanding of suicide. We're talking details about bullying. Remember, there's an intersectional module only on gender, and the whole mental health impact on gender suppression, the gender diversity, the gender equality, the issues of gender-based violence. Then there's a module totally on drugs, alcohol, substance abuse, because we know it's highest interlinked into mental health or in any other system. So these are all interconnected, interlinked web under the mental health umbrella. So, so building a holistic youth is very critical in the form of a skill, and mental health needs to be built from a skills perspective and from a very young stages. Should you be prone at high risk from a genetic reasoning or risk to mental health, or you're having, at least you are on your back mind aware from the beginning, this exists and it's possible, and you need to seek help. And then comes the layers of the infrastructure towards the health. Higher Health has also put 24-hour totally free helpline. The curriculums of the mental health that we have built from grade 9 thinking, from basic literacy level on a skills building, is in all languages in South Africa. It's in all 11 languages, the sign language, because I think you are talking about community development on mental health. You cannot put a language barrier towards the community development. So a lot of precision of work has been taken in terms of understanding and building mental health resilience in communities, keeping every sensitivity of a thing, because you're fixing something, but on the other side, another elephant remains. So I think removing elephants around mental health are very critical before we tackle this elephant called mental health, when we talk about community strengthening and community system strengthening. Chair, I will highly recommend that with PHASA in future, if we can look at a collaboration towards our model and the impact results of our model. This model has been running over the last so many years, but over the last 3 years, we scaled it up from a level of, we don't have clinical associates at this moment on mental health, but we do have mental health nurses, we do have counselors from the old registered counselor mechanism, we have peer educators who are purely built on mental health, and then we now have psychologists and of course psychiatrists. A tier level approach of how the education system, the early risk assessment, the linkage to different layers of care, some data on peer counseling results. We've got a lot that is happening on mental health at this moment in the post-school education. We're not talking about small numbers. We're talking about data as high as about 350,000 learners into mental health programs. And this gives us quite indication. We're scaling them up at a very regular pace level. And this year, we kind of going in an ambition of over 1 million young learners into the system. So there is a lot of data, there's a lot of work, but we like from a public health level to see how community strengthening systems can lead to eventually, because our main result of impact, which should come out in few years from now, is have we been able to reduce the burden on our health system by tackling mental health at a very early skills building preventative level. Obviously, that data will be the decisive decision making. But you're totally right, Prof. Skills is the way to go forward, and we are absolutely in line towards the skills system on mental health. Appreciate.
Thank you so much, Dr. Ramneek. Dr. Tshuma, your take?
Thanks a lot, Chair. I must start off by acknowledging the fact that, speaking after such eloquent speakers have spoken, there isn't much to add. But there are certain elements that I would want to talk to. Particularly tapping onto what Prof. Robertson said around simplifying the mental health messaging and have more targeted messaging. I think what needs to happen is that we need to have a lot more co-creation of the nature of messaging that we take out to the communities, where we sit with the communities, we let them know the technical and simplified jargon associated with mental health. However, we then ask to say what could be the most ideal means through which that this messaging could be disseminated. And I think it's one of the key things that made the COVID-19 messaging go viral. So there must be a co-creation of messaging with the end beneficiary. There must be engagement with community leaders, be it particularly in the hard to reach communities, in the rural areas, that we find most of the people dealing with mental health, but they are not reached out to. And there are fewer civil society organizations or community-based organizations that find themselves in that particular space, but with a huge volume of people dealing with mental health issues. And I think one of the key things is to look at cultural sensitivity around mental health and dealing with mental health issues. And this is likely to influence the nature of health communication or mental health communication that we push into the communities. So there is a need to ensure that there is also co-creation activities are culturally, socially inclusive and sensitive, and taking into account the diverse backgrounds, beliefs, values within the communities that we work in. And this may involve adapting facilitation techniques and also language, the manner in which we will facilitate these particular sessions at a grassroots level, and the language that gets to be used, and also the material that gets to be used for each of these target groups. As you saw during COVID, there was a lot of use of social media that came into play, hashtags, infographics, videos. You talk about across all WhatsApp, Facebook, Twitter, Instagram. There was some messaging that was targeted, whether we're using cartoons or we're using any of the local languages, in some instances even sign language, and all of these aspects, they play a key role in shaping our health promotion and communication of mental health messages targeted at the different communities. But key is the co-creation phase, is that prior to us disseminating this messaging, let's desist from high-level technical information that normally does not get to be understood and promotes myths and misconception around the subject. Let's come up with means jointly with the communities, with civil society organizations, with community-led institutions, so that there is buy-in and uptake of the messaging, and this messaging tends to be tailored to the target groupings at a grassroots level. That way, in the words of Ramneek, it will translate to community system strengthening. And with community system strengthening, we are likely to translate to improved provision of services and increased sensitization of communities. And that messaging is going to stick to the people's heads. And through repeated exposure to that same messaging, you will find change happening at a community level and increased awareness happening at a community level. Thank you.
Thank you so much. I'm going to take questions from Lillian and Emma. Over to you, Lillian.
Thanks very much, Constance. So my name is Lillian Dudley, and I'm a public health medicine specialist affiliated with the University of Stellenbosch. My areas of interest are largely around health systems. So I'm going to comment on those, but firstly, just to thank PHASA for shining a light on this hugely important area, but also hugely neglected. And to thank the speakers, in particular Prof. Moodley, for the really excellent presentation and for highlighting not just the burden of disease of mental health and the demand for care, but the extent of the unmet care and issues around access and human resource capacity. But let me just start my comment on the broader public health issues which have emerged. And I think Prof. Moodley very eloquently highlighted that the social determinants of health are an area that we need to be addressing for mental health. In particular, structural issues like unemployment. And I'm hearing some really exciting developments around building resilience at a community level, but it'd be useful to know to what extent we are looking at primary prevention and to what extent there's a whole of government approach to mental health. Clearly it's not something which the health sector on its own should be addressing. And are we as PHASA or as public health practitioners more broadly engaging with other sectors sufficiently to begin to address prevention comprehensively? Moving then on to the health systems issues, I think Prof. Robertson highlighted that we do have legislation, but as with many other areas, there's a failure to translate that legislation into implementation adequately, and over 20 years, which is a real indictment on the governance and leadership around mental health. So, just a question in terms of governance and leadership, where does accountability lie? What are the responsibilities of some of the role players? And again, coming back to PHASA, what is PHASA's role in advocating around governance and leadership? Policy document. Sorry, there's background noise. Pamela. Thank you. Because it really all seems to start there as well. If we don't have adequate governance, leadership, and the policy is not being translated, particularly around decentralization of care and building capacity within the district health system, then we really are not going to begin to address the huge demand for care. And I think Prof. Moodley has very adequately and eloquently highlighted the human resource constraints, but also some of the opportunities in terms of clinical assistance and, as well, or clinical associates. The question is to what extent that also links with the COPC approach. We are also building a cadre of community health workers throughout communities who are linked with the primary healthcare system. How are they also being brought in to provide community-based support for mental health, both on the prevention side, but also early detection and support side? And then the other area that you've highlighted is around measurement. And I know there's a bit of discussion in the chat as well, and I see colleagues have contributed to that. I'd just like to pick up there. I think there's some suggestions that we need to be measuring more things and some constraints around adding more things, and the burden on primary healthcare providers, but certainly also at other levels of the health system in adding data or indicators to be collected. I think we really need to step back and look at what is already available. One of the hats that I wear is on the board of the Office of Health Standards Compliance. And through the early warning system, as well as the national norms and standards that the office collects data around, there are numerous measures around quality of mental health care, which certainly I think would inform the state of the quality of care in the country. And I would suggest that if there is going to be any engagement around measurement, that some discussions need to be had with the Office of Health Standards. Mental health care has certainly emerged from the data that the office collects as an area of huge concern. Everybody's obviously very aware of the Ombuds reports on life epidemic, but there are numerous other incidents that are being reported to the Office of Health Standards from mental health care facilities, which are very concerning. And that is something that I think should be brought into the discussion as well. I'll leave it there, but thanks very much. And maybe just to again commend PHASA and to suggest that mental health working or special interest group certainly has its work cut out for them, and all the best to them to pick up on all the issues which have been raised today. Thank you.
Thank you so much, Lillian. And I'm going to go to Emma.
Thank you, Constance. My name is Emma Chademana from One to One Africa. I actually had a question for Prof. Ahluwalia. I don't know if he's still there. It was relating to the early risk assessment that he mentioned. I wanted to just find out whether that has been implemented with rural learners, and secondly, what happens when there are issues that are identified and risks and mental health issues? What is the referral system? Because some of the observations that we've noticed working in the space of mental health with adolescents and other population groups in the rural Eastern Cape is that there's really a huge shortage of the mental health support. Yeah, I'll keep it short to that. Thanks.
Over to
Thank you,
you,
ma'am.
Dr.
Thank you, Constance, and thank you, ma'am. I was about to leave, but thank you. I got to hear you, and so so our programs are quite standardized towards every setting in South Africa. So remember, we got the advantage we have is that we got sites at every part of South Africa. So there's a site in Bizana, there's a site in Ulundi, there will be a site in Alex, which is peri-urban or informal settlements. Soweto, we bought 8 sites. So like this, we got infrastructure in every space. And you're right, rural becomes our biggest challenge because it's not just about the risk assessment, it's also about what happens next after that. So our methodology is we use the class. So as I said, there's a module which is mental health, which is credit bearing. It goes into the system, and there are assessments. So some are credit bearing assessments, and some are non-credit bearing assessments. Because health is voluntary, we have kind of made this assessment for young people to take at early stages on identifying risk of themselves for mental health. So that is the risk assessment toolkit. It's been kind of piloted for many, many years in the peer system, while it's now become popular in the post-school system or in the education system, let me put it this way. When the student takes the risk assessment, so last year, 300,000 learners did the risk assessments on mental health. About 68,000 of them put themselves into risk of mental health. Some people can answer wrongly, or do not want to reveal the information because it's personal between them and higher health, which is very confidentially kept. However, there's an element, because it's self-assessment, there's always an element that person doesn't want to reveal. But what it does is, it does tell the individual on areas that he or she enlightens them towards risk. But we found out 68,000 of them were at risk to mental health. Some of them, what we do is we have a 24-hour helpline. We link the person immediately. So we automatically, it's now we are trying to build it on an AI platform system where once you do the risk, automatically there is a linkage form that comes with your name, ID number, and everything, which is your personal, which goes back to you as an email address. You can use this to present to any health practitioner around you in order for you to seek some support into the next steps, if you're in rural area versus in urban area. Our mechanism is you go into a 24-hour helpline, the number is there, you phone, and then they help you to understand your situation and guide you to the next nearest geospatial facility around you. We got an MOU with all the Department of Health in all the provinces, but that's not the only step we have. We have our own system. So as I said, we then link it to a counseling unit in an institution of higher learning. If the queue system is very long or the case is very acute, then we take it on a back-end system. So higher health also has its own mental health unit, which is run by counselors, psychologists, and clinicians. And they start seeing the level of intervention that needs to be done at that stage. Some are manageable through the system that we have. It's not a very gold standard system, but it's built in a way that it can absorb some pressures all the time. And then the referral pathway then starts going into a 3-tier system: private health system, public health system, and as well as in the NGO support systems that are around built in this. What I'm trying to say is Professor Moodley's presentation gives me an openness towards now looking at this new cohort of population that can be brought in. Professor Moodley, we can actually check from our current tier systems, well, when we can put them there, how much pressure can this alleviate away from the linkages system that we have built before it enters the mental health system in the Department of Health system. These are systems that sectors are putting now in order to absorb the pressures of mental health that they are facing or they are grappling with. Similarly, you have units of mental health in private systems, in public institution systems, and everywhere, where they are trying to grapple with this epidemic by themselves before they scale it up into the tertiary system. And I think that's the right cascading model from a community into the Department of Health system, which is the tertiary level system or secondary level health system should be moving into. So I think, ma'am, this is how we are working. So we are taking the risk assessment and then putting the linkages to a system where they fall as per the risks are identified. But from the risk, they go into a call center, and from the call center, the assessment is done to where they will be linked towards. Thank you.
Thank you so much, Prof. I'm just going to, Lillian, your hand is still up. I'm not sure if it's a follow-up or hand. Just to take if there's anyone with from the audience who has a question to Dr. Moodley and our panelists, you can raise your hand. I do not see a hand from any. Mine would be to the panelists and Dr. Moodley to say the question that I can pose, if you can just in 2 minutes each answer is, how do we leverage on the existing multi-sectoral structures within communities where there's civil society, there's government, there's private sector, giving an example of councils that are there, whether it's a Human Resource Development Council or HIV, TB, and STI Council, the AIDS councils. How can we leverage on those to promote mental health and to ensure that even in families, if it is social development, in their programs and skills development programs on parenting, they include modules on mental health. Just a take from all of you as panelists. I can start with you, Dr. Ramneek, because I think you wanted to leave.
Chair, thank you very much. Chair, I probably will advocate that what you have said. We've started that anyway. So we have a huge epidemic of exactly what Professor Lesley said, throughputs. We're measuring how many throughputs or dropouts in our system are linked to, or directly or indirectly linked to mental health through the determinants that, of course, are reasons for our dropouts. We have to pull our skill system back if our economy has to improve, and that's where higher health's main role is in the business. And we have no other choice than to really upscale community systems on mental health and putting structures in rural, urban, peri-urban systems before the health system comes into the picture in order to really solve the bigger crisis of skills productivity in the country. And from that angle, we've seen mental health very critically. We have started putting into the early stages of young people entering into the system. Similarly, the skills that are there, which are not in education and not in employment, we have started working with NYDA, National Youth Development Agency, the NYS, the National Youth Service, and very critically with PHASA now, which is very important element where 18 to 35 years of age group in PHASA grantees are a very critical cohort for us to be able to pull the mental health promotion through the form of modules in education and early risk assessment profiling at early stages to build resilience in these people. So these are our cohorts where we are working with different systems in order to penetrate and quicker build system strengthening around it. So Chair, from my side, to sum up, the model has to work cross-sectional. Every sector, every community service, every system needs to take mental health as a KPI and then build into it itself, and then move into a tier system linking into the Department of Health mental health system eventually. Thank you, Chair.
Thank you so much. Your take, Prof. Lesley?
I'm feeling a little overwhelmed. There's actually so much, and about building it into the system. I'm just, yeah, I think, and I'd like to actually go back to the whole aspect of accountability and responsibility, and where do we begin as well with the system? And I think what we need to do is start working on what do we want to see? What is the outcome that we'd like to see? And what are we aiming for? It's very difficult for people in any of our sectors, public sectors, to put effort and money and time into any program where there isn't an outcome. The education system is on matric results. It's, the health system, we're looking at mortality data. And unfortunately, it's not even years lost to life that we look at. It's just simply the actual final cause of death. So there's no measure for mental health, and there's no way of pushing people to integrate it or to put money into integration. The word integration is used very liberally. I was told from our National Department of Health once, well, how can you fund mental health at primary care when it's integrated? It's meaningless. And every chief director and CEO says, oh, we have to integrate it, but we haven't got any guideline on what that actually means, and there's very little awareness of it. So I would like as a take home to say that we need to work out what we want to see. And I think, was it Mr. Nyembezi who said, Dr. Nyembezi, who mentioned the happiness report, and I think that's a very good place to start. But we have to drill down further once we've got that outcome and say, what is the responsibility of each sector in achieving that? And in terms of accountability at higher levels, and somebody said at higher levels, it's trust and trustworthiness. Other aspects, reducing the access to substances, making sure we're not somehow or other through our issues in politics supporting global syndicates and drug trafficking and human trafficking, our trauma. It's vast. So for me, the happiness report is a place to start and then to work out what each sector needs to do and what are the quality outcomes that we need to examine. Thank you.
Thank you so much. Dr. Nyembezi, in just 30 seconds, your response, and also Dr. Tshuma following each other like that.
Yeah.
Over.
No, thanks, Chair. I think for me also it's just the issue of just make sure that we promote health promoting environments. We should create those, and I think we will do well in any settings, be it a family, being at a workplace, being at a school. We should create health promoting environments. Thank you.
Thank you so much, Dr. Tshuma.
From my side, I would say the same way we have got multi-sectoral and multidisciplinary collaboration for HIV and TB. We need to integrate or to bring in those elements when it comes to dealing with mental health. Thank you.
Thank you, Dr. Moodley. Your take, and also to wrap up on the discussion that has been made, if you can just make a concluding response to that. Over to you.
Okay, thanks, Constance. I think maybe just to start off by saying, I think there needs to be acknowledgement about mental health being a significant public health issue, and for it to be prioritized. I know when I first started doing public health, we said that there's some criteria that need to be met for us to think that this is something that's important in terms of public health, and if that, that it's very common, that it could lead to severe disease, that it has high economic costs, and there's something we can do to prevent it. And I think all of that applies in this case. So I really hope that PHASA kind of leads the way on this issue. And then I think what's clear is that we need a strengthening of the mental health system as a whole. And there we're talking about issues around leadership and political will to implement policy, ensuring that there's adequate budgets allocated to mental health and mental well-being, addressing issues around the health workforce, and particularly access in rural areas, which I think are largely ignored in terms of mental health services, health information systems that need to integrate mental health, and then look at how best to deliver services. And there, as you said, we need to integrate this into communities and collaborate with organizations into the communities, in communities, so that mental illness is recognized quite early, as well as people that have been diagnosed and treated are accepted and managed in communities once they go back. And there we're looking obviously at the mental illness aspect, but obviously mental health and mental well-being is much broader than that. And there's a whole package of things, and much of that has come up today, which we need to look into. Yeah, I think those are my concluding remarks. Back to you, Constance.
Thank you so much. And just want to appreciate Dr. Moodley, the panelist, Dr. Robertson, Dr. Ramneek, Dr. Nyembezi, and Dr. Tshuma for your contribution, in the audience for your contributions in this webinar. And just to highlight that it is clear from the discussion that we need to strengthen the mental health system in the country, and we have to come together and design a model for mental health and ensure that it is inclusive and everyone is involved, and clinicians, the civil society, private sector need to be part of this, and no one needs to be left behind and should continue to be activists. And I'll say to PHASA, we have to be intentional on this matter. We have to advocate for elevation of mental health services to be accessed by the communities, and we have to ensure that promotion education is elevated in a manner that we attract even funding around issues of mental health. So thank you so much for designing this session and for involving me. From Constance to all of you, have a blessed day. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you very much for the
Bye.
very
Thank you.
beautiful
Bye-bye.
information. Thank you. Bye-bye.
Thank you. Bye.
Saiendrah.